Welcome to Health and Harmony Beyond the Teeth, where we dive into all subjects that will help you become healthier and happier. As a dentist, I believe dentistry is more than just teeth, so I created this show to focus on overall health. We will hear from leading experts about eating better, exercising better, breathing better, and sleeping better. We want to help you create harmony in your life so you can live your life to the fullest. We want you to thrive.
Hello, welcome to Health and Harmony Beyond the Teeth. I'm Alex Kelly. I am Dr. House Stewart's daughter, and today I am guest hosting his podcast yet again. A few weeks ago, I guest hosted and interviewed him, Dr. Stewart, about just some questions when it comes to tongue and lip ties in kids and adults, breathing disorders, fluoride, all of that. But today, we are joined with Dr. Adriana Corredor-Stewart to talk tongue and lip ties specifically for infants, newborns, up to around 3 years old. So how are you doing today, Dr. Corredor?
Doing good.
Yeah, thanks for coming. I know that this is a topic, as a mom and somebody who talks with a lot of moms every single day. I think that there is just a lot of talk about tongue and lip ties, but not enough accurate information. And it can be very overwhelming. So I told this to Dr. Stewart when I was interviewing him last, and I know you probably already know this, but just from personal experience, when my first Miles was born, thankfully I had you guys in my life and I knew what I knew, but in the hospital, my doula told me, I can't remember exactly who said what, but I know it was something to this extent of my doula told me, he has a severe oral restrictions. And then the hospital pediatrician came in and they were like, oh no, he doesn't have any restrictions at all. And then I met with an IBCLC and she was like, yeah, he might have some restriction, but we can work through some things. And I was like, for a mom who doesn't know what they don't know, like that's very confusing and very overwhelming. And so the first thing that I wanted to ask are, what are some things that moms should be looking for in a provider who is diagnosing and or treating a tongue or lip tie? Because I personally don't think everybody out there that's treating oral restrictions or diagnosing them necessarily maybe should be, if that makes sense.
No, absolutely. So, two things come to mind right off the start. One of them is making sure that the provider is performing a functional oral assessment and also that believes in a team approach. So let me come back around. And for those maybe mothers that are new to this oral restriction world, I think I'll start with what are oral restrictions, because there are so many different kinds. The oral restrictions, I think that most people hear of, for example, a tongue tie. So collectively, we have oral restrictions, lip ties, tongue ties, labial ties, or buccal ties are all referred to as tethered oral tissues or tots. And so you have, you can have, for example, let's talk about what a labial or buccal tie. That's the tight tissue that connects from the cheek to the gums. A labial tie or a lip tie will connect that tight tissue from the lip to the gum. And a tongue tie, or the medical term ankyloglossia, that's where you see that tight tissue connecting underneath the tongue, but it's limiting the tongue movement or function. And with the tongue tie, we also have anterior tongue ties and posterior tongue ties. Anterior tongue ties, and the studies out there show that they're about 4 to 10% found in infants, whereas the tongue ties are about 32%. That's what's reported in most studies, actually happening more in boys than in girls. So I think the biggest part here is an adequate assessment of the anatomy and the function. So a tight tissue in order for it to be a tie, like a tongue tie, must impact nursing, feeding, sleep, and speech. So I think the biggest area where it's not so much misinformation. I think it's just, like you said, misdiagnosing, but more important, just not misunderstood. These ties are not understood well. And, if there was one thing that you'll remember from this today is that it cannot be assessed just by a visual, by appearance. It has to be it has to be paired up with function. And that thing, in looking at both of those things, then the provider can make a much more accurate diagnosis, and for sure, result in better outcomes. But the team approach is huge. And let me explain what I mean by that. Um, so somebody comes to me and, we dig a very thorough medical history. I'm not only looking at the infant or the toddler, but I'm also getting history from the mom. And we can go later about what I mean by that. So then next we'll do the actual visual assessment. But what is missing, I think, a lot of time is that functional oral assessment. We need to be checking mobility. We need to be checking function. We need to be checking how these oral structures are functioning, not just appearing. But in the big part of that is having a proper assessment. So, for example, a lactation consultant, I think it's crucial because they're going to be looking not only at the oral structures, but how are they functioning? How is this infant feeding? What does that look like? So that the assessment is kind of two-part. They're not only looking at the infant, but they're also looking at the mother. What are her issues? It's this partnership it's like this beautiful dance between the mother and the child, and there's so much that has to happen at the same time. So a proper assessment of what it may take an hour or whatever that looks like, but assessing of everything that's going on during that time. And because that's going to help me as well to narrow things down, but also to better inform the parent of, okay, these are other modalities or therapies that are really going to help your child. It's not just about releasing the tongue tie. And so lactation consultants or feeding therapists is extremely important. It could be craniosacral, so therapies such as OTs and PTs. It could be a pediatric or pedo chiropractor, myofascial therapist. But those are going to serve at some point. And sometimes the baby, that's all they need, is just they need to be released of that tension. So I think team approach is extremely important. And I think too many times parents are coming in and they're being told, oh yes, you have a tongue tie or lip tie here, just release it, without properly informing the parents that there's a lot more. Because the last thing we want to do is perform something that something else was missed, and later on this parent's coming back to me and say, well, my child had a release as an infant, but now they're here with all these oral dysfunctions that are still present.
Yeah. Yeah. Another personal example, and my youngest, Evelyn, she had a buccal, cheek, tongue, and lip release. But we started off seeing a craniosacral therapist, a body worker, and just from that alone, I could tell tension was released.
Yep.
Her kind of like stomach issues got a lot better just from that. There was still some clicking though, and so then I went and saw a pediatric dentist, and they took a look, looked at function and everything, and they said pretty confidently, like, she's got some pretty severe buccal restriction, which our craniosacral therapist noted that as well. But they said, but we're not, when it comes to the tongue and everything, they're like, we don't want to make a definitive decision until you go and see the IBCLC that we work with. And that was a requirement.
Yeah.
And I know in particular, I was talking to one mom who said there's a dentist in her community that's pretty much known for, if you walk in and tell him I want a tongue tie release. It's like no questions asked. He'll do it right then and there. And I was just like, oh my gosh, no.
Yeah, yeah. I think it's important to make sure we know, what are the challenges? Is it a oral anatomy? Is it a technique? Is it a functional limitation? Because, and even having even let's say the release is needed, a tongue tie release surgical procedure is needed. Well, having seen a feeding therapist, a lactation specialist, is going to help also provide post-op support, because it's not about just removing the obstacle, it's also about preparing the body. So I think sometimes, too many times, I think parents go in with one thing, okay, it's all going to be better after this is released. And that's not true for a lot of cases. And so there's other restrictions. So talking about, so I named the tissue restrictions, but there's also other restrictions oral restrictions, such as tension in the palate, tension on the floor of the mouth, that's going to affect the movement of the tongue. There's also tension, muscle tension. It could be a nerve tension. So those have to be, or should be, identified, because again, these are may not show up now, but they will show up later. And so when it's
Yeah.
better to address them, to recognize them early on, instead of later.
Yeah. So to kind of recap, would you agree that if somebody is going for, a consult or an eval and their provider, is talking about recommending going to see an IBCLC as well as, some sort of craniosacral therapy or body work, that is a green flag? You would feel more comfortable with a provider
Absolutely.
versus one that's just like, yeah, let's just do it, not even mentioning
Yeah. Yeah,
the
because the last thing we want to do is to perform a procedure that isn't really needed. And like in example with Miles, your oldest one, you were being told yes, from one extreme, and no. I looked at him and he seemed fine. I mean, I did a functional oral assessment, and I remember we finally said, okay, let's do a lactation assessment, which you did. And shortly after that, I think with you was just you were misinformed. I think at the hospital, you were told that you only needed to feed on one breast. So,
yes.
but he ended up not needing it. So imagine he would have gone through all that and maybe continued to struggle because you were not informed correctly. So I think that's a perfect example. So team approach is huge. And for me, the more we can support our moms, it's such a crazy time they're going through, and their bodies are going through all these changes. The more we can support them with the right information to get down to the core of the problem, what is actually going on, sooner than later, is always better.
Yes, definitely. So you touched on these next two questions a little bit, but I want to dive maybe into more detail. So can we talk a little bit more about why specifically seeing an IBCLC or a feeding therapist prior to a release or before making a release decision is so important? What kind of things are they going to bring to that team approach?
Well, they're going to do a complete assessment of not just of the infant, but also of the mother. So we try to figure out where are the challenges, where are the obstacles. And like I said, sometimes it's just a matter of poor positioning, or sometimes it's the mother. The mothers are so wired up and so much tension within their bodies of having gone through that whole birthing process, that their nervous system is all wired up and they need some. So a lactation assessment is extremely important, because it's not just about the infant, but it's about the mother, and then trying to bring them both together to see where's the challenges, where's the obstacles, and removing that obstacle. And so they spend time with you. They spend hours watching the baby feed, and how is that happening? How is the suck, swallow, and breathing pattern? What does that look like? And so they just can, because that's what they're watching for. It's such a great, it's so crucial and essential when it comes to me deciding, okay, is this patient, this infant, are they ready? Do they really need it? And are they ready? Have they been supported by it's almost like checking off the box. Yeah, we've done this, this, and this. That hasn't resolved. Okay, so then it must be, because I will tell you that not all visible ties are problematic, and not all problematic ties are visible.
Okay, I was going to ask, is it possible for an infant to be nursing completely normal in the sense of they're gaining weight, there's nothing, the mom's not in pain, there's no visible or like maybe audible clicking, kind of those red flag signs that we know to look for? Is there possible to have oral restrictions with basically not even knowing?
Yes, they are. Yes, it is possible to, well, okay, there's two parts to that question. Yes, it's absolutely possible to have a tethered oral tie or tissue, an oral restriction, and not have feeding problems, because we compensate, and as human beings, we can compensate. So, but we develop compensatory patterns that at first a baby or an infant may tolerate just well, but later on will show up. And at first, sometimes there's just not much effort needed, that, for whatever reason, the mother has great milk supply, so they're not having to work so hard. Um, Whereas later on, if that wasn't addressed and all the signs were there, something's going to show up later on. If the tongue isn't working properly, it wasn't properly identified, it was missed. But that tongue sits down low, it's going to show up later on when the teeth start coming in, because the tongue isn't in the right place. It's not developing that palate as it should, because of the position, it's not up. The infant can't raise that tongue up. So it'll show up later. Whereas the other side of that is, there could be, oh, I just messed up what you were just asking me.
Uh, well, so I asked, is it possible to have an oral restriction without visible signs? And then I can't remember. Maybe it'll come to us in a little bit.
Yeah.
Are you able to address, maybe in more layman's terms, of what are the possible consequences of not identifying and releasing an oral restriction, a problematic oral restriction early on? Because you said things will start showing up later. What might that look like?
So let me answer that flipped first. Let me say, what are the benefits
Okay.
of getting earlier, having the release earlier on?
Yeah.
So most of our eating and drinking skills are developed in the first 2 years of life. So at birth, 40% of our facial growth has occurred. At 3 years old, 50%. At 6 years old, 60%. So if we're not, if we don't have that tongue, or if there's an oral restriction present and it's not released early, then it's going to affect growth and development, right?
Hmm.
So the benefits are, making sure that this infant is not going to have feeding issues, or oral craniofacial development, that everything is developing as it should. So we have a saying here: it's easier to treat a diseased child than a broken adult.
Hmm.
So the bad thing, so the consequences of not doing it or not recognizing it and doing it early on, is affecting that transition that's going to occur when an infant is trying to transition from breastfeeding to solid foods.
Hmm.
And so the infant, the toddler, is going to struggle. Gagging, choking is going to occur. They'll develop certain swallowing patterns, tongue thrusting. So that, at first, an infant, the way they swallow is they have that anterior tongue thrust, but will transition normally into a functional swallow. So if that's not recognized and it's not addressed, this is where I get my picky eaters. They're gagging. They're very messy eaters because they have all this dysfunction with either the tongue, the lip. They can't clean their, the feeding is abnormal. They can't cleanse a spoon.
Mm.
So there's a lot of other dysfunctions that start occurring because they're trying to compensate for something and they're just trying to do their best. So sleep delays can occur as well. But more importantly, out of all of this, is that cranial facial development that's not going to occur as it should. So then later on, we're looking at all of these other dysfunctions that we have to correct, but now we have underdeveloped jaws. And now, so in treating all of this early on and recognizing it, our hopes always is to get to them sooner than later so that we don't have a child that, will have to have ortho treatment, expansion therapy later on, or worse, develop into an adult that has now all these other issues because they weren't addressed, end up with sleep apnea and all the comorbidities that go along with not being able to breathe and have compromised airways.
Yeah. Yes. So I feel like I had another question and it is not coming to me. So so we talked about the importance of seeing an IBLC. Oh, this is what I was going to say. So would you say that just like, most moms, when they have their baby, they usually already have their pediatrician picked out at that point, or very shortly after, they go see their pediatrician for their, like, whatever it is, week old appointment or 2 week appointment. Would you say it would be beneficial to, just as part of that kind of checklist as a new mom, is also finding a, um, you know, airway provider or a tongue lip tie provider to um, just take a look?
Yes, absolutely. Absolutely. I think that is the biggest, I talked about, you asked me earlier, what steps should a mom take in order to get a correct diagnosis and then also have a good outcome if the procedure is needed. The one thing I think, and on top of not doing a functional assessment and having a team approach, is not long-term monitoring the
Mhm.
progress of a child. So there's so much that occurs between birth and 3 years.
Yeah.
And so much is happening. They're going from a, anterior thrust to a functional swallow. So that's changing. You have teeth that are coming in, these jaws are growing. And this is, if we're not tracking, that's a missed opportunity. And
Yeah.
so this is a perfect example. You can have um, you could have addressed something early on and that was it. And then you don't follow up. And so then 5 years later, something else arises. There's a really good study or an example. It's used a lot in the dental community. And it involves a 10-year-old child. I think he's a son of a British physician or something. And there's a picture of him. He's 10 years old. He's got broad face. He's showing a broad face. He's his lips are closed. He's nasal breathing. He looks healthy. At 14, he gets, I think it's a gerbil as a present. And shortly after, he develops an allergy. So now his nose is blocked. So now he can't breathe through his nose and he becomes a mouth breather. 3 years after that, then they show the picture of him at 10 and the picture at him. So we got it at 14, so at 17 years old. And his face has changed considerably. So his facial features are now, he's got a longer kind of a sunken face. His lower jaw is kind of set back. I'm trying to picture his face. He's got a double chin. You can see the dark circles under his eyes. He just does not look healthy because he has now been mouth breathing because of his congestion or whatever from the gerbil in his room, or I think he kept it in his room. All to say, all of that has resulted from mouth breathing.
Yeah. Wow.
So to go back to it's kind of a long explanation, but yes, I think it's in pediatricians, I mean, I'm sorry, but a lot of them don't know. They tell you one thing and then they come to me, I'm like, no, 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 no. So I think it's just a very, it's a critical time because so much is happening, but I think it's the most unknown, or education, the information is not there enough. And what I'm trying to do here in our practice is develop kind of a protocol where, if I have, because we have infants that are, moms bringing their infants, and to keep them, and I will say, I need to see you, in 2 months, in 3 months, because I want to keep tracking. So much can happen. You leave, you go out my door, you're fine, but what happens in between all of that? What allergies have developed? What food sensitivities, food that can trigger inflammation? What has happened? And there's a lot that can happen. And so I think, yes, I think tracking early on, finding a home where you can go back to. We're not a pediatric office, so we don't do fillings and cleanings on kids, but we do craniofacial development. And so we will see the infants and we'll keep tracking them, because again, we want to keep monitoring. We want to make sure that this child is on the right path, because a lot of things can throw that off, and we just want to be able to have families know that they're supported here, and educating them of like what to look for, what's next.
Yeah. And I think as a mom, I understand that it can be overwhelming of like, oh my gosh, there's just like another thing I have to do. But
Yeah,
I always tell moms of like, look,
yeah,
you're going to have to find a dentist at some point for your kid.
yeah,
So you might
yeah,
as well, I mean, because there are pediatric dentists that do the fillings and the cleanings and the
correct.
checkups that are also very well informed on tongue and lip ties.
Yeah,
So if it's overwhelming, I say you have to find one anyways. Just find one that you, like you said, you can call your home for all of that.
yeah,
And then you're done. And then they can follow that baby from week one all the way up into adulthood, because it's something you're going to have to do anyway. So,
right.
might as well um, choose one that you can stick with. And I like the way that you phrase that can be your home.
Yeah,
And so I know it can be overwhelming. But like you said, there's definitely long term
yeah,
benefits as well,
better,
especially if you catch it early, then
absolutely.
yeah.
Better to recognize it early on, because and then it's easier to fix and remove those obstacles, but more importantly, to provide and support these kids so they can thrive, and I mean, I just, these kids, a lot of times they don't know what's going on, and you have all these behavioral issues that that develop because of that. And so it can be very overwhelming. And again, it's it takes a village to raise kids nowadays. And I have heard that so many years, and it's so true. But again, being well informed, there's so much good information out there. There really is. There is a book, it's kind of like my Bible, by Diane Barr. So nobody ever told me, or my mother, that. So there's this one that's really good. There's another book that she has, that kind of just walks you through. There's checklists in there, but if for a first time moms that you don't know, or what, there's a lot of good information in there. And I think the more you are informed, the more you can make better decisions. And knowledge is powerful, and then the more it at first can be very overwhelming, but then the more the more you see things, I think sometimes I mean, that will definitely help.
Yes, and I'll throw out there as well, and then we'll get into craniosacral therapy.
Mhm.
I mentioned this in the last podcast episode with Dr. Stewart, but if a mom is just needing a really, you know, quick way to narrow down providers to look into, I know the Breathe Institute
Yeah,
has an online search engine where you can find providers near you. They have a wonderful oral restriction residency. I know you and Dr. Stewart went through it. And then they don't have a search engine, but it's Dr. Baxter. I don't remember his first name, but he has
Richard Baxter in Alabama. Yes,
it's called like the Alabama Tongue Tie Center.
yes, yeah,
They don't have a search engine, but I have messaged them before. And if a mom messages them on Instagram or emails them, they could provide um, a provider near them. So I know I can just see moms sitting there being like, okay, well, I know now what to look for in a provider, but how do I even
How do
begin
I
finding someone? And so if you kind of want to just speed up the process, those are two trainings I know of. And I think you would agree that are pretty reputable.
Yeah, and the other thing too is if you do find somebody or you can't, you look it up, you look somebody up online or you get a recommendation from somebody and you do go and it doesn't feel right, trust your instincts. Mothers are, it's amazing. And I have my mom, for instance, is a perfect example. When I was younger, I was coming into high school and started my ortho. Again, I had to go through braces and orthodontic treatment, and I'll never forget. I have forever to thank her for this. But um, the orthodontist said, "Oh, yep, we're going to need to extract 4 teeth because my front teeth were overlapped and there's a lot of crowding." And that was his first thing. It was like, "Yeah, we have to extract 4 teeth. I've got to be able to fit all these teeth in." And my mom looked at me and said, "Nope, I don't care what you do, but you won't do that. So find any other way to accommodate all of her teeth." So as a mom, I mean, she doesn't come from, I mean, I'm the first dentist in her family. And so she didn't know, but she knew that it didn't seem right. There was a reason why we have all our teeth. So it was her instinct that told her gut feeling, don't do that. And so forever I have like for her to thank for. So that's one of my biggest, recommendations, or I mean, to trust your gut instincts. And so if you're at a provider and things kind of seem hasty and fast, and you don't have enough information, and just things don't feel right, don't do it. Or go and
Yeah.
have a second opinion. There's no harm in, you're your child's best advocate. So
Yeah, absolutely. Yeah. Oh, I hear stories all the time of my
yeah,
dentist is telling me we need to pull 6 teeth. I'm like, oh my gosh,
I
no.
mean, yeah.
Okay, so we talked about the importance of seeing an IBCLC um, before and after having a release. Let's talk about the importance of craniosacral therapy. But maybe before we get into that, would you say, because I know there's just kind of general
Mm.
chiropractors, and then there's craniosacral therapy, and chiropractors can definitely be trained and be practicing craniosacral therapy on a daily basis. But would you recommend specifically craniosacral therapy when it comes to, um, you know, the oral restriction team, or is just general chiropractic okay, or what would you say?
So, okay, so I would say to that, oral restrictions are more than just tight tissues in the mouth. They're going to impact the whole body. They impact the neck, the jaw, the our breathing, or the way we posture. Um, so let's go back to what body. So I recommend body work. And body work is light touch to release tensions. It can be done by a craniosacral therapist. It could be done by a myofascial release. It could be done with a chiropractor or like a pediatric chiropractor. It can be done by a physical therapist or occupational therapist. Um, I think the biggest part is some of them are not trained to release or to work inside the mouth. And so, because you have these oral restrictions that can cause other compensations or tensions, then in my opinion, most kids or most infants are going to need work inside the mouth. So as long as I know there's a lot of chiropractors that can work inside the mouth, but you have some OTs and PTs that cannot. They're just not trained. So I think it's knowing how much is needed, and so again, we work with all of them, but at some point, sometimes I need an infant to be worked inside the mouth, and that's where your craniosacral therapists are going to be more well versed, and they do it every day. But the other thing is osteopathic physicians. There are a lot of osteopathic physicians that do strictly craniosacral therapy, and so those would be another great provider that we collaborate with that I would definitely recommend. And again, I think there's so much that can be released by going inside the mouth, that doing outside techniques just won't address that.
So why is it so important to have that work done pre-release and or post-release? Why is that important?
Um, Pre-release because you want to release some of those compensations or address those compensations. Especially with a baby, infants, going through birth, I mean, that's a big process and it can be very traumatic. And so, for example, even if it was a perfect birth, there's a lot of compression that gets applied to the face. If it's a vacuum delivery, that using that vacuum will result in a lot of fascia throughout the whole body. So it's really important to release all of that because you're going to have a much profound release if a tongue tie or a lip tie release surgical procedure is needed. And so again, it's removing the obstacles. How can I best support this individual so that if a procedure is needed, that they're at their best or at their best position or time? When is the right time? And sometimes without that cranial sacral work or that body work, the child just isn't ready. So we want to make sure that we're preparing the body before, but then also supporting the body afterwards.
Okay. Okay. And I think, going back to when we said finding your home, if you find that dentist that really knows what they're doing when it comes to oral restrictions, um, they should have local referrals, I would imagine, for craniosacral therapists and IBCLC. So you're not having to kind of find all these different providers, I at least I would imagine. I know you guys have your IBCLCs, your craniosacral
Yeah.
therapists that you work with. So it's not like you have to be like, okay, I have to find a dentist. Now I have to find an IBCLC. Now I have to find if you find your home, they should all be working together and have those referrals for
Yeah.
you.
The other thing too that we've seen a lot with infants, kids, even adults, is working inside, doing craniosacral before, can really help work on vagal um, pathways. So if you have somebody, a child that you had digestion system issues, or just calming them down, doing some of that cranial sacral work beforehand and after can really, really help. The other thing is working inside the mouth before can help really align misalignments, that are happening around all these bones in the face, but also in the body. So again, it's just removing those obstacles
Yeah.
that are sometimes they're masked and we don't know, but just knowing and seeing this over and over again, if you don't know what you're looking for, you don't know. But I think that's where that team approach is so important, being able to collaborate with other providers. I can't do everything, but I can recognize that I'm going to send you to somebody that is well versed and can really help you. So we are here kind of like your home base. We tell you, we can advise and we can see and we can recommend, which is why that team approach is so, so important. But the craniosacral before preparing the body for that release, again, it's not about just releasing it and the tongue is going to know what to do. No, we've got to work through all those compensatory patterns that most likely developed because of that restriction. They just don't just go away immediately. So we have to kind of prepare the body and work through that.
Right. No, that makes total sense. And like I mentioned, craniosacral therapy alone helped so much with Evelyn.
Yeah.
And then I have to wonder, I mean, I know every child's going to be different,
Mhm.
but her recovery was like easy, like
Yep.
nothing. And I do wonder if part of it was because she did have all of that tension released
Absolutely.
before. So it's going to be an easier recovery, I would imagine.
Right. Yeah.
Um,
Yeah. Just keep calming the central nervous system down. Absolutely. That's going to be huge. They sleep better. So if you sleep better, you're going to restore better. You're going to heal better.
yeah.
Um, and not only on the infant or the toddler, sometimes the mothers, having, because you feed off it's not just the baby, the infant. It's the mothers. The mothers, they um, addressing their needs as well is huge. And so that's sometimes working on both, and but being able to recognize and acknowledge that is huge. And it's yeah, I saw it with your kids, and we see it every day. It's just we are so, it's like myofunctional therapy for older kids. We can't do tongue releases. We can't do that without, and Dr. Stewart that does the toddlers or the children and the adults will not do a tongue release unless they've gone through myofunctional therapy. And so you can't do myofunctional therapy on an infant or even some toddlers because it requires participation from the patient. But for infants and young kids or toddlers, definitely the cranial sacral can kind of help replace some of that, as well as other things like you're doing oral motor exercises, and we can talk about that. There's different mouth toys that they can use to, again, be building some of that strength and working through those compensations.
Okay. Yeah, I want to get into some more specific questions next, and I don't even know if I have that on my list, but I do want to come back to that, and I'm actually just going to make a note so I don't forget.
Okay.
So, okay, so we talked already about signs and symptoms a parent can look for that might indicate an oral restriction. Let's dive into that a little bit more, because there is such a huge difference, obviously, between a newborn and a 2-year-old. So
Sure.
let's start with newborns first. I know we've already addressed that sometimes symptoms will not be as obvious, and so this is why we recommend just finding that home right off the bat. But for those cases where maybe there are some obvious symptoms for kind of newborns and babies, what are some signs and symptoms a parent can look for that might indicate problematic oral restrictions?
So I have it here because I broke it down in like infants to 12 months. So I have them all and I kind of generalized them. So for infants, you would definitely be looking for difficult or feeding difficulties, whether it's breast or bottle. So you'd be looking for like clicking sounds while feeding, gassy, colicky, reflux-like symptoms, a poor latch, a shallow latch, frequent or prolonged feedings. Sometimes these infants, they're struggling and they're working so hard at feeding, they just get tired and then they fall off the breast. But then they wake up and they're hungry. So it's like this vicious cycle that just continues. So difficulties staying latched, milk leaking out of the mouth, falling asleep at the breast, or poor weight gain. Other signs in infants would be watching the tension in their bodies. Sometimes they're that stiffness or they're arching backwards, mouth breathing, noisy breathing when sleeping, blisters on their lips when they're sucking, preference on one breast or one side, especially like with infants with torticollis. Clicking or popping when using a pacifier or bottle, and then milk pooling in the cheeks. Um, One that actually comes to mind, and this is one that I've kind of have heard more and more of, is, for example, I've had a patient that went and saw their pediatrician and had was misdiagnosed. They had white on their tongue. So the pediatrician saw and said, "Oh, yep, that's thrush." And so now they get put on antibiotics. Well, it's not thrush. It's a coating of milk because the infant is not utilizing the tongue properly. So the tongue isn't going up to the roof of the mouth, cleansing off the tongue. So that would be one. That's one that I think is a common one, and that again is very misdiagnosed because it was told to that patient by a pediatrician because he didn't know what, not used to that. So for toddlers and children, I would be suggest looking at feeding and swallowing issues. So these are going to be my kids that are picky eaters, that are gagging, choking, slow eaters. They take a long time to eat. Their mouths are open. They have open mouth posture. They cannot elevate the tongue, so they really struggle with that tongue movement. Um, swallowing pills, and then that's kind of, I would wait a little bit older, but speech delays for sure. Others would be, and I think Dr. Storm might have covered this, would be sleep and airway signs that include, of course, the snoring, mouth breathing, drooling on the pillow, bedwetting past toddler age, dark circles under the eyes, and then any hyperactivity or attention difficulties, forward head posture. And then other things start looking at is crowding of teeth, narrow palates, um, high arched palates, any clicking or popping, or like compensations drooling, like they can't close their mouth. I had a child the other day who was like 5, I think he was 5. And mom, that was one of her complaints is just her daughter just always kept the mouth open. I mean, like she was really struggling to swallow her own saliva. So that would definitely be one to look for.
Um, do you, okay, so make sure I'm reading this one correctly, because coming from a mom, can you give some encouragement to moms who might be hearing all of this, and maybe either they have a young child and they did have a release, but they didn't know any of this, and it was kind of just your general release. They didn't do the craniosacral, they didn't meet with an IBCLC, and they might be sitting there being like, oh my gosh, well, I didn't know, like, am I doomed, what do I do? Do you have any encouragement for them, or what to look for, what to do? Because I can just see, I know that that's so prevalent, and I can see moms hearing this and being like, well, I didn't know.
Yeah, well, and again, I absolutely, we see that, I have seen moms come in and, my infant had her, time release as an infant and now we're here, or I breastfed till they were 2 years old and now you're telling me that they still need expansion. So, it's never too late to treat an oral, um, tissue restriction. So of course, the sooner, the earlier you recognize it, the better. But remember, up till 6 years old, 60% of their facial growth has developed, but there's still 40% left after that. Even up to 12 years old, there's still their faces are still developing and growing. So encouragement would be, it is what it is. Just recognize what you're dealing with now and go forward. Again, there's so much that we can do. We can redirect the growth and development of that child. So the sooner the better, because they can thrive. So we can easily change the direction, so that they can thrive and they can develop. And so that hopefully later on, as an adult or as a teenager, maybe they do need ortho, but it's going to be a lot less to correct and a lot less to fix. Um, there's a lot of things you can do. There's toys that can be purchased and utilized to really develop those motor skills. Chewing, diets, one of them, having a good diet that you're transitioning, even if you didn't transition, depending on where the age is, but really have a diet that reinforces those chewing muscles, that makes them work out. It's so warm to see. So Evelyn, your 1-year-old, was with us this last weekend, and it warmed my heart so much to actually see a 1-year-old have a piece of a steak in her mouth and just gnawing, just chewing on it. And she's got 2 teeth on bottom. That's it. So I loved that. And she didn't choke and she didn't, she was just enjoying it. That hand and eye coordination and everything that goes along with that and the development. Oh, so it's never too late. Um, Again, there's exercises that you can do to keep encouraging that development, just depending on where their age is, um, and and come and seek out a provider that can help you. There's a lot that can be done. There are silicone oral appliances that are available through a dentist or online, and those can include your mild munchies, your mild braces. Again, they all encouraging that development, utilizing the mastication, the muscles of chewing, but also helping with nasal breathing. Where is that tongue supposed to be? So they're all promoting nasal breathing, which is what we need to have the growth development, the proper growth development.
Okay. I want to address something about the solids and then maybe go into more detail of what parents can do at home. But I think that a lot of parents, especially new parents, are very worried about starting solids like baby led weaning and choking and all of that. And my encouragement is, and I don't know if this is actually true, but I believe I read somewhere that I don't know up until what age, but your gag reflex is actually like lower at like that 6 month to
Yeah,
whatever age. And so by doing like baby led weaning and actually serving solid foods appropriately earlier can actually help prevent choking later on because they are learning how to chew, how to eat, how to take appropriate bites. And there's a great app called Solid Starts
yep,
that you
yep,
can search literally any food and it tells
yeah,
you, it shows you visually exactly how to cut it
yep,
safely for that age. And for the like 6 month to a year range steak, the recommended serving is like a big slab of like a really chewy steak because Evelyn loves chewing on steak. It is, and she only has 2 teeth. It is virtually impossible for her to choke on it. Of course, if you're giving her little, round
sure.
bites, yes. But if you just give them a big slab to chew on, I mean, it's virtually impossible for them to choke.
Yeah.
Yeah.
So baby led weaning, as you mentioned, and any of there's several apps out there. Solid Starts is one of my favorite because it has been, there's a lot of good advice. There are professionals that have, you can find information about, like you said, how to cut them, like what age. I mean, it's very, very, very comprehensive. I mean, you can find anything, like you said. So it's a great, great app, and it's free. Um, as far as choking, I think the most of the reason why, and that's a valid concern of a parent, like, oh my gosh, how do I transition this? And so again, one of them is following an app or following the baby led wean. There's a book, I think I have it here. Oh yeah, here we go, baby led weaning. So there's a really good book that talks about all of that, and it's a guide and it has checklists and all of that. But the biggest, I think the biggest take on that, or information I can give you, is when you feed a baby or an infant, you're basically forcing that, and they may not be ready to take it. So it's a much natural way to develop these oral motor skills as well as that tongue when you allow the baby to reach. So at 6 months, that's when they start reaching for things. So kids are not, or infants are going to learn, one, by what they watch, but also in developing their going through their milestones in their development, they're going to learn that. So reaching out, when's the right time? So when a baby can sit upright and hold their head up pretty good and starts reaching, that's the right time to start introducing that. And you let them explore, you let them learn on their own. It's very different of a child going in because they're going to know where to put it or how to put it. It's missing all that, but they're not going to shove it into their face, right? Whereas if you take a spoon and you're feeding them, they may not be ready to take that, and you're doing a lot of the work for them. When they're doing it on their own, they're having to figure out how to turn off that anterior tongue thrust, and where is it going to switch now to a functional swallow. Of course, again, if there is a tongue tie, that's going to be a little bit harder. So again, it's about recognizing this early on. But I think the safest way is to allow the child to do it on their own and to figure out, let them develop those milestones on their own. Now, if it comes to a time where, an age where they're struggling and you're watching things happen, then that's different. And that would be a one sign to have them be evaluated, because you're right, there could be a true tongue tie or oral restriction that's present that's not allowing them to be able to do that properly.
Yeah.
So, but the baby lid, that's why I really, really, and I kudos to you, Alex, for doing that with Miles, with Evelyn. because they're good eaters and they have no issues. But more importantly, that's also going to help them develop and have that craniofacial development that is so crucial at this age. And so, chewing, working those muscles, an infant's diet and their facial function is what's going to form the face. So the more
Yes.
we allow them to develop that, the better.
Yes. So let's get into, and we can start with a diet.
Yeah.
What, and you touched a little bit on some things, and this is the last question I have. And so then at the end, if you have anything else you want to add, we can do that. But what are some things parents can do from day one, starting at home, that really encourage proper craniofacial development? So we can start with diet, because I think that, we can, a lot of our food, a lot of the baby food and toddler food and even adult food, I think Kimberly, describes it. It's already pre-chewed, like, which, and I'm not judging anybody here because we enjoy all of these ourselves, but pancakes, waffles, chicken nuggets, pouches, all these really soft foods, they're basically pre-chewed. So you're just having to pretty much just swallow it. So
Yeah.
we'd say things like, steaks, and Miles and Evelyn both love to eat just whole raw apples. I mean, things that are really going to require chewing, I think is a good start. Anything else you want to add to that, or what are some other things parents can do to just encourage the best chance at proper craniofacial development?
So, like you mentioned, diet. Okay, so diet is crucial because it's okay. For first, it's going to build a strong and diverse gut microbiome. So
Mhm.
you're not going to get that from processed foods. You're not going to get that from sugary foods.
Yeah.
So that's extremely important. Um, the more we use our muscles, muscle is what grows bone. So if we're not having to work our muscles, we're not going to work our muscles to build bone. So you're delaying this development, this natural development that should occur. Um, a good recommendation, Weston Price, there's a foundation, and he was a dentist that early on in the 1900s that went out to different civilizations and just uh, explored and wrote a, explored on how they ate and their culture. And what he found that was very was the same in all these different cultures was that they ate their basic foods, their what their in oh gosh, what was it? No, okay, I just lost my train of thought.
I mean, I know, at least I've seen pictures. There's like a side by side picture of, I think it was almost like a tribe, and they ate,
Yes.
foraged and ate right off the earth, versus there was somebody that I probably American boy around the same age,
Yep.
um, and you could see the difference. The westernized boy's face was very narrow, very sunken, and then this tribe boy from this tribe who ate, off the earth, off the ground, raw vegetables, gamey meat. I mean, you could just see the difference in their face. I'll try and find those pictures to put them up here.
Yeah.
Yeah.
But Weston Price has a foundation, and there's a lot of good information in there. I think there's like guides to different types of foods, but all to say, the more we use, the harder we have to work at things, the more we're going to build that muscle.
Yeah.
When you suck on things or purees or soft foods, we're not working those muscles. And so also the tongue isn't having to work. So the tongue, we don't build the strength of the tongue as it should. And it's our tongue that's going to form our face, and it's our tongue that's going to you know get us to become a nasal breather so that we can thrive. So so the diet is extremely important because we in learning to eat and chew harder foods is going to build that muscle, which is going to also help with that coordination with the tongue swallowing and developing a proper swallow. um, Same thing kind of comes to mind as far as, for example, pacifiers, and thumb sucking. Well, the pacifiers are not going, they're going to intervene with that tongue. And so a pacifier may be great and it's soothing at first, but to some point, I mean, we can't, there's a lot of negative consequences that can occur when it's prolonged too long. At first, they need soothing, that's great. But we should wean them off of that because, again, you've got something that is strong that's interfering with the normal tongue function. And we need that tongue function to help not only with nasal breathing, but also developing the jaws. And so, again, the more we chew, the more, just think of chewing is what's going to grow our muscle, is what's going to grow our faces. And so the more that we can, the quicker we can introduce that to toddlers, the better. Again, our picky eaters later on, if you don't introduce that early on, it just gets harder. It gets harder to introduce that later on to a 7-year-old or an 8-year-old, and so the more we can address that sooner the better, because we want to, again, follow a nutrient-dense diet, and avoid the sugars and the processed foods.
Yeah, yeah. I was going to say, going back to the pacifiers, there's I kind of laugh at there's the orthodontic pacifiers that are supposed to be designed so that your teeth aren't shaping around them in X, Y, and Z. And I'm like, okay, well, first of all, if your child already has all of their teeth in, they shouldn't be having a pacifier anymore. So the orthodontic pacifier is kind of, you know, not it shouldn't even be a thing because they shouldn't be using a pacifier. But those orthodontic pacifiers, or a lot of these pacifiers, are real bulbous, or they hook
Mm-hmm.
to the palate. And so I know if you're going to choose one, there are like the Philip Avent Soothies, and the Ninny are more like cylindrical shaped. And so in order for that pacifier to stay in your mouth, there has to be active tongue movement. It's not one that's just going to hook and stay in place. And so I have heard people saying, like, or I've heard, I know Dr. Norizagi recommends those, of like, if you're going to choose a pacifier, choose one that's more cylindrical shaped that requires active sucking. And if there isn't active sucking, it's going to fall out. It's not something that's just going to hook onto the palate. Would you say there's a specific age? Like, okay, let's say a mom is like, no, I'm going to use a pacifier. Is there a certain age or time frame that they should really work on dropping it?
Yes, it shouldn't extend past 12 to 18 months.
Okay.
And why is that? Well, that's because, like you mentioned, 18 months, maybe a little bit earlier, but we want it definitely before all of the teeth are in. But because okay, so two things come to mind with the pacifier. Again, yes, it works as soothing for a lot of infants, and early on is fine. And it may help with sleep. It may help with regulation, for some of these infants. But prolonged use can also develop in eating problems because it limits the development of the proper tongue, of the position of jaw movement. So we don't want to interfere with anything with that. But the other thing too is when you are using a pacifier, that can also encourage ear infections because it's a different motion that is occurring, and so now you can't drain the ears as you should, so the infections can occur more frequently. And so again, anything that interferes with the natural development of the jaws is going to have a consequence. So the more prolonged that pacifier is in the mouth, the jaws aren't growing this way, and so what's affected is the drainage, and it's going into the middle part of the ear, causing more and more ear infections. So that would be one of them. Several reasons why. Again, it's great at first, but not for prolonged.
Yeah.
And there's other ways to help with that soothing, that need. You can transition. I think it's definitely, I would advise to transition off of that pacifier and to possibly using mouth toys, something like this, and that can help stimulate and provide that soothing, that what infants are looking for, but it's more but it's going to be more beneficial. And something like this is going to definitely help, and not only because it's got the different textures, so it's going to simulate different textures of foods, but also helps an infant to not only hand and eye coordination, but also start chewing on it and to build and to start using those muscles.
Yeah, yeah. I think along kind of the same category of pacifiers, we obviously, there's no judgment to moms that choose to breastfeed or choose, formula or bottle feed. There's never any judgment, but just from a, scientific standpoint, breastfeeding provides more benefits when it comes to craniofacial development. But with that being said, I always like to tell moms there are better bottles to choose. And a lot of the more popular bottles that I see, and I'll throw some pictures up here, but I know one that comes to mind is like the Tommy Tippy bottle. And it's a very short nipple and a very round like base. I'll put a picture, but you can see that it forces a child, a baby, to have a very shallow latch. But then there's bottles like the ones we use, the even flow balance. And again, I'll put pictures up so people can visually see the difference. It's very like gradual shaped, and so it promotes more of that deeper latch. And I think a lot of parents just aren't aware of the bottle that they choose can have huge benefits or consequences.
Absolutely. Yes.
I'll put some pictures up to see. And it makes me so sad because there's one bottle in particular that comes to mind, and they kind of market themselves on mimicking the breast. But the only part that mimics the breast is the actual bottle part, not the nipple. And I'm like, well, the bottle has nothing to do with it. It's all about the nipple.
Right.
So that one always drives me crazy when I see it because I'm like, oh, it doesn't mimic the breast at all. It looks like one, but it doesn't function like one.
Yeah. What you have to remember, or I always try to tell patients or parents to try to remember, is that, yes, there's a very different mechanism that is used when you're bottle feeding versus breastfeeding. So if somebody, a mom that has to bottle feed, my suggestion, recommendation would be is then do other things that can override that, or that will complement, the motion or the mechanism that would be used with breastfeeding. And those are going to be your, oral exercises, or using mouth tools, toys that they can, chew on, to build that strength. Going back to pacifiers, something I just kind of thought of is, when you're prolonged pacifier use, because it changes the pressure and the drainage from the into the ear, and then can cause ear infections. It's like a vicious cycle, because now this child has, or toddler has an ear infection. So what, they go to the NT or the pediatrician, and what do they get from that? They get prescribed an antibiotic. So now we have, recurrent ear infections. Then we have recurrent applications, or using antibiotics. So what is that going to do? That's going to ruin or have a big effect on the gut health. And this is where I think a lot of ENTs don't understand, or don't address, whether they understand or not, just don't understand, is that link between gut health and inflammation. And so if we don't have a healthy gut, we're going to have inflammation throughout the body. The more our immune system has to work. So tonsils and adenoids are part of our immune system. They're going to swell up to trap the germs that come in through the mouth and through the nose. But what happens is, when there is such a like chronic occurrence, or inflammation continues, whether it's triggered by a food sensitivity, or an allergy, or something in the environment, it's going to affect the inflammation throughout the body and affect enlargement or inflammation, and we end up with inflamed tonsils and adenoids. And so now I have a parent that goes to an ENT because they have all these issues over here. The ENT says yes, they're enlarged, let's get them out. But have we removed the obstacle? Have we figured out what caused the congestion or the inflammation to begin with? And so, and tonsils and adenoids can grow back. And so again, I tried to, always try to tell a patient or parent, it's not just one thing. It's usually multifactorial, and there's a lot of moving parts. But to me, it only makes more sense if we find the source of the problem and address that, because then we put the body in a much better position to heal on its own, and those tonsils and adenoids can regress and go back and reduce in size. Now, if I have a toddler that isn't breathing, can't sleep, then that's different. But for a lot of, we can catch the ages between 2 and 6 is when the adenoids and the tonsils and get the most inflamed. If we can minimize that by addressing all these other issues, it just makes more sense to me. So,
well, I mean, yes, because our tonsils and our adenoids have a purpose and a function. So if they're not functioning, okay, let's remove them, but we're still not addressing why they're not functioning, because whatever is causing them not to function or to, be inflamed is still going to be there. So
overwhelmed, yeah. Why is the body so overwhelmed? Why is the immune system so overwhelmed? Gut microbiome or gut health is huge. Which brings me, I found recently so here in our office, I have a patient that will come in, and I suspect that there might be a food sensitivity. There's a difference between food allergies and food sensitivities. There are a lot of kids that are coming in with these food sensitivities that it may be a healthy food, it's just their body is reacting to that certain food for whatever reason. And so we do have a test here, KBMO. It's a food sensitivity test. It's pretty easy. It's a prick of the finger. We send that out. And there's different levels. We usually do on toddlers, we might do the 130, but there's different options you can pick. There's one that tests 176 different types of foods. And then there's another one that I think it tests 132. But it also will look for markers for gut inflammation that may be linked to leaky gut or linked to leaky gut. But all to say, I think it's important to identify those food sensitivities because, again, you can have a child that, for example, blueberries are healthy, but for whatever reason, maybe the source of where that blueberry is coming from, their body is reacting. There's a high reaction to that. So if we can remove that obstacle and go through a protocol, elimination diet, and then you introduce those foods that may have come that may have come back highly sensitive to, we slowly introduce them back into the diet. We're allowing the body to heal. There is one other online that a lot of families, if they can't come in, you can actually request. Tiny Health is one of them. And they have all different kinds of tests. They even have where you can do the whole family. They can do it for pregnant women, but because it's extremely important to also know what our gut health is. If, this something that comes to mind when I have a mom and an infant come in, when I'm going through their thorough history and going through all of that, I will ask a mom, what was your nutrition like before your pregnancy and during your pregnancy? Because their gut health is going to be what their infant's gut health or very similar. So if I have a mom that was nauseous throughout their whole pregnancy, I know that has to do with gut health and probably wasn't digesting her food and getting. So what kind of nutrients was this infant receiving? So I think it's extremely important to look at those things. And again, it's about just trying to figure out, remove the obstacles. The other one that comes to mind would be also mold toxicity. And mold toxicity causes a lot of chronic congestion. And if we don't address that, again, we can have tonsils and adenoids removed, but there's still going to be obstacles there, and their patients still going to continue to struggle.
Yeah, no, definitely. I know it's so many, there's so many factors that can play into it. I know it can seem overwhelming, but it really can have such a huge impact on
Yeah.
overall health for the whole family.
For the whole family, absolutely.
Yeah, it's interesting you say that about like diet during pregnancy because with Miles, I had preeclampsia, um, and I didn't have a bad diet, but with Evelyn, I was definitely much more active, and I ate a extremely high protein diet when I was
Yeah.
pregnant, and I had no preeclampsia, no swelling. I was still nauseous with her, but I was able to get off medication when I was pregnant with her, whereas Miles, I wasn't, and I think that that played a huge role. Uh,
Yeah, yeah. I mean, NOS should be the first trimester. That's normal, but it shouldn't last the whole pregnancy.
yeah,
So again, that's just an indication, yeah, of gut health. And so I have a mom that's struggling through that, and now she's going to be breastfeeding. It's going to pass on to the baby. So the baby is going to be, the gut health of that baby will be the same as the mom. Now, if I have an infant that wasn't born through wasn't a vaginal birth, that was, for example, a C-section, well, now this child has two things against him, that mom had poor gut health, and he didn't get the seeding of having gone through the vaginal, or the birth canal with a vaginal birth. So now, that child is also behind that on their gut health. So, again, you just have to look at there is a lot of moving parts. And so again, I go back to the more we can educate, the more we can inform parents and patients, not only as an infant, but maybe possibly prior to or while they're pregnant. It's just, again, supporting families to be in a much better position so that there's less they're going to have to deal with later on.
yeah, and it's Miles again. Like I had preeclampsia with him. Um, he was ended up being a C-section. Weight gain issues, but that was not due, as we mentioned, that was just due to poor advice. But it's like he kind of had all of the things against him. But obviously, I wish I could have set him up, um, you know, even pre-birth. But sometimes things are out of your control, and there's things
Right.
that you do. Like it's not the end of the world. He's doing great, and so but yeah, but that is why I am very passionate, especially through that experience of just educating
Mm.
moms because you don't know what you don't know, and
Yeah.
you can't beat yourself up for
No.
making decisions when you don't know what you don't know, and you like you said earlier, you know what you know now, and so we're just gonna move forward and
Forward. That's right.
even if you're starting all of this, you're starting this journey at 8, 9, 10, even 12, 13, I mean, that's going to set you up for more success than if you are just discovering this at 65.
That's right.
Yeah, it's never too late. Even at 65, it's not too late.
It's not. Absolutely. And for moms that, already had one kid or thinking about having another and being pregnant again, having another child, there's a lot that you can do to put yourself in a better position to go through that pregnancy.
Yeah.
And so, because if I have a mom that has sleep issues herself, or sleep apnea, your tissues, your child, your infant, your baby's tissues are going to be oxygenated as well as yours are. So there's a lot that in preparing and for next, pregnancies, there's a lot that can be done before so that you're not having to, or maybe dealing with less things later on. And so again, it goes all back to, we're here to empower, to educate, to bring hope, and encouragement to families, to mothers. And you do the best you can, and moving forward. And if you had a child or an infant, or a child that had an infant, as an infant, had a lip release or a tongue release, great, but if they still have issues, okay, well, let's look at again, it's identifying other obstacles and removing those obstacles so that we can best support your child. And that's what we're about, is that we, in which why we collaborate with so many different providers, because we can't do it all, but we can direct you and we can refer you to the right person so that you get the right treatment and information.
Yes, yeah, that's great. Remember I went to a myofunctional conference with you and Dr. Stewart a few months ago, and I feel like that was kind of one of the biggest takeaways that all of the speakers were talking about is the importance of a team approach and acknowledging as a provider that, I can't do all of it. And so, let's work together. I think a lot of times it's easy. I know sometimes I'm nervous with certain providers to go and being like, well, this provider, said this, and I'm scared they're going to be like, well, kind of judgmental. It's like, no, providers should be working together because you can't do it all. And one provider might see something that, the other isn't able to. And so, yeah, I love that team approach mindset. Um, that's all the questions I have. Was there anything else that maybe I missed or that's really kind of important for moms to know? I think we covered a lot, which was really good.
Yeah. I think you had asked about what can be done, or what encouragement from mothers that have already kind of missed, like, or that are dealing with toddlers or older kids. Um, again, there's a lot of toys out there, or mouth tools, besides the myobrace. Um, oh, just gonna lost my train of thought.
Is
Uh,
it the Iowenshi?
oh, I just lost my train of thought. No, gosh, what was it? No, I forgot. No, I don't know. I was gonna say something. Not the
I
my.
do I do want to ask you about this. I don't know if this would be a question for you or more for Dr. Stewart because I think that it's more for older kids. But you're just talking about the Myo brace. Um, I think, and I'm starting to see this. I know of this program through you guys, but I'm starting to see more moms that I just know of online mention it, and so it seems like it's kind of gaining traction. Do you know much about the tooth pillow, Dr. Moralia's? I mean, I know you don't know Dr. Moralia, but do you know
Yes.
much about tooth pillow, or would that
Yeah.
be more of a question for Dr. Stewart?
I believe the tooth pillow is a support for a lot of families, like in more rural areas where they don't have direct access to a provider. So it's a way to assess them online. I think it entails the parent taking a few photos, and then maybe answering a couple questions, and then sending that off to a provider for tooth pillow. And then they meet online virtually, and then they recommend an oral appliance to promote that nasal breathing.
Okay, I
So
was gonna ask if it's not expansion. Is it?
no,
Okay.
no, it's about no. Now, some of those silicone oral appliances, and we do use some here. And again, it depends on the need of the child. We don't have like a cookie cutter protocol. It's, the patient comes in and we're assessing and trying to figure out what's the best time, or what is that child need at the time. There are other oral appliances that have an expansion component in it. But the tooth pillow, I believe, and I could be wrong, but I believe it's more about that first stage of promoting nasal breathing. So it encourages tongue position. And so the more the child can tolerate that in their mouth, especially at night, then we know that they're nasal breathing. And then then I think after a point, when they've kind of maxed out, with the benefits of that oral appliance, then they can be referred to another provider that will actually, if there is need for expansion, then they can be referred to somebody that will actually do treatment that will require either like a fixed appliance, or any other type of oral appliance that has that expansion component in it.
Yeah, I'm looking at it here, and yeah, it looks. I mean, I'm sure it's different than the Myo Munchie, but kind of that like silicone. Uh,
Mhm.
yeah, okay, yeah, I've been seeing that pop around a lot. It seems like it's kind of gaining.
Yeah, and the good thing about that is too is, you, as a parent and knowing and having somebody kind of looked at your case
Yeah,
and has
yeah,
advised you, yes, I see signs of underdevelopment, or I see signs of feeding difficulties or speech delays, then they can advise you, yes, at least start here. Whereas some of these, I think, if I believe, like a mile, not mile, but it's the mile munchies, I think it's open to the public and you can go and order them. But are you using it correctly? Is it age appropriate? Or have other issues been identified? Again, it's about recognizing the signs and the symptoms early on, because the earlier you recognize those, the more you can help your child.
okay,
So it's a way to advocate, to help parents kind of navigate through when they can't find a provider nearby, or they live 2 hours, or so it's something to at least start.
yeah,
Because
okay,
again, if you can get that nasal or that tongue working properly, and you can become a nasal breather, if the tongue can work and do what it needs to do, that's what's going to grow the face. And so, our tongues are our natural orthodontic um, appliance in our mouth. And if it's in the right place and it's working for us, then we gain all the benefits. It's when it's not working for us and it's sitting down low, promoting mouth breathing, that's when we're not getting the benefits.
right, right, okay, yeah, no, that makes total sense. Um, okay, great. Well, I don't think I have any more questions. I think we covered a lot, and I'm hopeful that this can really help. Oh, I think Miles is about to come in here. I'm hopeful that this can really help a lot of moms that are kind of just getting started on this journey of learning about craniofacial development and airway and jaw growth. And all of that. So I will put it out there for anybody who's listening. Dr. House Stewart, Dr. Adriana Corredor are located in Flower Mound, Texas. But there are great providers throughout the states. Again, the Breathe Institute is a great program to look into. They have a search engine. Um, Dr. Baxter's, I think it's the tongue
Richard,
ties.
Richard Baxter,
What did I say? Yeah.
Richard.
Richard Baxter. It's like the Alabama Tongue Tie Center, specifically for oral restrictions. And then, of course, when we're getting into um, older kids and airway health, Dr. Moralia has a program. But yeah, this has been very helpful. So I think, is there anything else you want to add? I think we covered pretty much all of it.
Um, yeah, I mean, there's a lot more we could talk about.
I think
Uh,
we're gonna try to do another episode
yeah,
with Dr. Stewart, like specifically, and I'm sure you can join in on that, specifically on more details of like actual treatment once you get into those older kids that might need, expansion and things like that. Because I think it can seem very daunting. Um, but I think it's probably a lot more minimally invasive than parents kind of imagine. So I think we're going to plan on doing an episode really diving into the details of what that
okay.
looks like. So yeah, we'll have to get that on the books. But
Well, and thank you, Alex, for having the passion and and eager to help so many families, out there, and mothers that get very overwhelmed. And it is overwhelming. I can only imagine, with all of this, you're going as a mom, or as, especially if you're breastfeeding and all that, going through all these changes yourself, and then having to worry about another individual and all their, issues. It can be very overwhelming, but there's also a lot of good information out there, a lot of providers that are willing to help and want to help. Sometimes it's just, it's a journey, and sometimes it may take a while to get the right answers. But I just wanted to thank you personally, because I know you've done an incredible job. You have your own Instagram, right? Instagram, that you have a lot of followers and just a lot of good information on there that that are going to help mothers now or future mothers how to navigate through a lot of this. And I think it's very impactful to have somebody that's gone through it and sharing their experiences of what works, what doesn't work. I've tried this, I've tried that, but also that is the right information, because you're right, there's a lot of misinformation out there, but I think it has a lot more to do, just it's not, patients may not be well informed or completely informed. So they get a little bit, but they don't get the whole thing. They don't get the whole picture. And so we don't just look at ties here or tissues. We look at the whole body and the whole individual. So.
Yes. Well, thank you so much. I appreciate that. And I appreciate you. This has been Health and Harmony Beyond the Teeth. Thank you so much for listening. And thank you so much for joining us, Dr. Corridor.
Thank you.